I want to thank everyone who's taking the time to listen to my presentation today. And what I'm going to hopefully be able to do is describe to you my experience in pediatric sleep, most importantly in the private practice, which is something very different than many of you are probably experienced with. I'll begin by stating that the birth of my sleep lab in a private practice setting was born out of necessity. And as the great Plato said, necessity is the mother of innovation. What I'm showing you now is a schematic of the area in which I practice. I'm showing you the areas of Alabama, Georgia, and Florida, and the gold stars are areas where there are major centers for pediatric neurology care. And my practice is located at the location of the blue star. So you can appreciate the enormous catchment area that my practice right now is covering, because from the blue star and going to the right of everyone's screen until Tallahassee, there really isn't any pediatric neurology practices. And so we see an incredible volume of pediatric neurology referrals. And with these pediatric neurology patients come a wide variety of sleep problems. And so one of the patient populations that was most prominent in terms of having sleep disorders was the autistic population. And that was a very common problem that I was seeing with all the families who were coming to me, because their biggest concern was the fact that their child did not sleep well. I ran into these same problems in my epileptic patients, my cerebral palsy patients, a variety of genetic disorders to include trisomy 21, Prader-Willi, and Rett syndrome, as well as having sleep disturbances in the ADHD population and children with migraine headaches. With the autistic population, the biggest problem that families complained about was insomnia, and that this was not only resulting in a disruption of the entire family dynamic in terms of everyone not being able to sleep because the autistic child was awake throughout most of the night. This was also exacerbating the underlying behavioral problems of this population. They were more agitated, they were more aggressive, they were more hyperactive and impulsive. In the epileptic population, we saw both sleep apnea, particularly during times when the patient was experiencing subclinical electrographic seizure activity, but we would also see significant sleep fragmentation, because many times the subclinical seizure phenomenon resulted in arousals, and the more frequent the seizures, the more fragmented the sleep. With the genetic population of trisomy 21 and Prader-Willi, due to their low muscle tone and their small airways and obesity issues, obstructive sleep apnea was an enormous problem. Rett populations have a dysregulation of their breathing patterns both during the awake state and the sleep state, and as a result, we see a high percentage of these patients with significant central apnea. With the ADHD population, they also experience significant insomnia, many times as a result of the medications that they're taking. Stimulant therapy often results in disruption of sleep patterns and requires treatment, because the more sleep-deprived the ADHD patient becomes, the more their clinical symptoms of inattention, hyperactivity, and impulsivity become. And finally, with migraine patients, we also saw sleep fragmentations, because many times their migraines would prevent them from initiating sleep, and quite frequently during the course of the night, migraines would awaken them, resulting in significant sleep fragmentation. What I'm showing you here is a schematic of Florida where there are American Academy of Sleep Medicine accredited labs that are capable of doing children. And as you can see, they're very few and very far away. If you look in the corner, in the left-hand side, at the panhandle where my practice is, you can see how difficult it was for us to be able to send patients to be able to get sleep studies. For any neurologist who deals with patients, it's always important to be able to document the condition that you're treating. For example, if you have a patient with epilepsy, you do EEGs as a way to be able to establish and monitor that condition. Imagine trying to do sleep medicine with no ability to be able to do polysomnograms or MSLTs. But that was the situation that we were dealt with. Many of the adult practices were not equipped to be able to deal with the special needs of the pediatric population. Their labs were not equipped for family members. The technicians were not familiar with children, especially those with special needs. And as a result, it was very difficult to practice sleep medicine without an ability to really understand the condition that you were treating. And so that's what prompted me to say we needed to have a sleep center in this part of the world. And so this is an example of one of the 5 rooms that we have in my practice. My practice is in a building which has an entire floor dedicated to neurophysiology. We have 5 rooms which have been built out as bedrooms and are running sleep studies at night and running EEGs during the day. The equipment that we use is the Cadwell EZ3 PSG and EEG device. The most important aspect of the way I approach sleep medicine is approaching it from the aspect of understanding that sleep and EEG are part of the same continuum, and that it is very important to be able to gather as much data from the EEG aspect as well as the sleep aspect. And I'll demonstrate that in just a moment. And also, from the cost-effective standpoint of being in a private practice, you want to be able to have one set of equipment be able to accomplish all the tasks that you need to be able to do in your neurophysiology lab. And so the equipment that EZ3 provides us is the ability to function as an EEG during the day and as a PSG at night. And so what I'm showing you here is an example of how the data is presented using the EZ3 Cadwell system. And the 2 things that I definitely want to point out is if you look in the upper left-hand corner, you'll see a blue bar which traverses the length of the EEG electrode channels. And what's important that I do in children is that I add additional EEG leads so that I'm able to convert the EEG data into a larger array so that if I see abnormalities during the course of the night, I'm able to then convert it to EEG data that I can look at exclusively in order to be able to determine whether it's artifact, sleep architecture, or true seizure. And that's a very big difference because when PSG, as you know, first came into being, they only used 4 channels. And most recently, it was increased to 6 channels to include some frontal leads. But the International League Against Epilepsy and the American Academy of Neurology, have stated that in order to be able to make a statement regarding interictal epileptiform activity, you really need to have an 8-channel EEG device. The other issue that I wanted to point out is down in the bottom where you look at the end-tidal CO2. We have a transcutaneous end-tidal CO2 monitoring device that's performed with all of our children's studies. And that's critical because when we're trying to assess obstructive sleep apnea, it's very important to be able to detect whether or not there's evidence of hypoventilation, which in many cases may be more prominent than actual baseline hypoxia in a child, because most children don't have the chronic lung disease or the chronic cardiopulmonary disease that you often see in the adult population. And as a result, when they have respiratory events, they may not necessarily have significant hypoxia. This is an example of taking the PSG data that I just showed you and converting it to a different montage so that you have the classic longitudinal bipolar double banana. And as a result, you can now look at the EEG data in isolation to determine whether or not you're seeing evidence of subclinical seizure activity. So in this particular case, you're able to run an overnight EEG while you're also doing a sleep study because you're working with the same data. And that was critical because in many cases with our population, it was impractical to run two separate studies. And then by turning the speed of the EEG data down to 10 seconds per page, this is how neurologists will read an EEG in order to make accurate diagnoses regarding subclinical seizure activity. Now, when I first opened my sleep lab, my initial impressions were that I was going to be uncovering a lot of obstructive sleep apnea, which hadn't been previously identified. And what I discovered was that in addition to obstructive sleep apnea, many of my patients were experiencing central sleep apnea. And this was something that isn't well written about in the sleep literature. And my proposal to you today is that I believe that this is a significant problem which needs more attention, more study, and more investigation. To remind everyone, central apnea is just simply the absence of airflow with the absence of respiratory effort. This is a schematic of a polysomnogram which indicates that in the blue box below, you have a cessation of airflow, which is then coupled with a flattening of both the chest and the abdomen channels. There is a different scoring method for pediatric central apneas than there is in adults. What they share in common is that the apnea is identified by a drop in peak signal excursion by greater than 90%. And that the duration of this apnea has been empirically designated as greater than 20 seconds or at least the duration of 2 sequential breaths. There's no inspiratory effort during the period of the apnea, and that if the apnea is less than 20 seconds, but at least the duration of 2 sequential breaths, then that apnea needs to be associated with at least one of the following. That it be associated with an arousal that immediately follows it, that there be a 3% or greater arterial oxygen desaturation, or that there's evidence of bradycardia marked by a heart rate of less than 50 beats per minute for at least 5 seconds. This issue came to light because, as I stated earlier, I started having a number of children who were presenting with symptoms that were suggestive of obstructive sleep apnea. Many of these children were exhibiting symptoms of excessive daytime somnolence, impaired cognitive performance in school, increased irritability, and were in many cases, being observed to have respiratory pauses during sleep, which led not only families but also referring physicians to believe that the patient was experiencing obstructive sleep apnea. But when the studies were done and I was identifying that these children were experiencing high numbers of central apneas, it led us to the issue of trying to find data as to what really constituted normal for age. And so what I've listed here are the 4 studies which have been published since 2004, which identify a range of normative data for children with regards to central apneas. And what you can see here is that the range seems to go from at least 0.4 up to as high as 1.1, based on which age study you're looking at. And when you compare this to adults, adults have established that central apnea is at least 5 or greater events per hour. But if we assume that we empirically establish pathology when parameters are at least 2 times the upper limit of normal, then what that does is it puts pediatric criteria for central apnea as greater than 2 events an hour. Now, this is currently being investigated by the American Academy of Sleep Medicine, and hopefully within the next year, establishment of normative parameters for children will be made. But when we look at the syndromes which are identified in the International Classification of Sleep Disorders, what is interesting to a pediatric neurologist that of the 5 established syndromes, 2 of them can have direct impact on the pediatric population. And again, when we look at the central sleep apnea criteria, we see symptoms which are very similar to what we would see in obstructive sleep apnea. We see excessive daytime sleepiness, frequent arousals and awakenings during sleep, wakening with shortness of breath. Again, this cites the adult data of 5 events an hour, and not explained by other sleep disorders. So when we think about children and we think about central apnea, the conditions that we have to be concerned about are those in which the brain has either been malformed or is abnormal either due to neoplasm or to injury. So what we have is 4 syndromes. The Chiari malformation is a congenital phenomenon in which the cerebellar tonsils have herniated into the foramen magnum, putting mass effect not only on the pons and the brainstem, but also obstructing the flow of cerebral spinal fluid, leading to hydrocephalus. The tumor is an obvious phenomenon, particularly when it is involving the brainstem and the medulla. Achondroplasia, again, another congenital syndrome in which the cerebellum and the brainstem are being impaired due to the shape of the skull and the cervical spine. And finally, hypoxic ischemic encephalopathy, when the brain has been damaged and the central mechanisms for the generation not only of sleep architecture but also the autonomic regulation of breathing during sleep have been damaged. These are 2 additional genetic syndromes, which we'll speak of one in the cases that will follow. Leigh syndrome is a mitochondrial disorder. Infectious processes can impact on central regulation of breathing. And finally, medications of opioids and narcotics. I feel that the best way to put all of this into perspective is to show you how patients who have come through our practice have been profoundly affected by our ability to be able to do sleep studies. The first case I'm going to tell you about is of a 16-year-old who was referred due to disturbed sleep patterns. And the symptoms that he presented with were hoarseness, difficulty swallowing, snoring, daytime somnolence, daytime napping, nocturnal arousals, and morning headaches. And so he had been referred by ENT, who had failed a trial of antihistamines and intranasal steroids and felt that he needed a polysomnogram to document obstructive sleep apnea prior to undergoing tonsillectomy, adenoidectomy. But the concerning issues with this case that I've highlighted in red are, the first was that he was hypertensive. His systolic blood pressure was 140. On physical examination, he had absent gag reflex and only minimal posterior pharyngeal sensation, which certainly raised the specter of cranial nerve dysfunction in the area of the medulla. When his sleep study was performed, again, no evidence of obstructive apnea was found, but he had evidence of central apnea, with his index being greater than 20 an hour that were associated with oxygen desaturations. And this is an example of that particular study. And as you can see, he was having runs of these central apneas with significant oxygen desaturations that you can see at the bottom of the screen, where his saturation in this particular epoch dropped from 95% to 90%. And when I have shown this slide in the past, in isolation of the history, it's been interesting that I've had sleep techs say, does this patient have Shane-Stokes breathing? And then I tell them that this is a 16-year-old with healthy lungs, a healthy heart, and just presented with disturbed sleep patterns. So because of his physical examination and because of what we were seeing on the sleep study, an MRI of the brain was ordered, and this is an example of that study. And as you can see in the bottom of the screen, you not only have evidence of a Chiari malformation in which the tissue, as you can see, is herniating into the cervical canal, but you can also see an oval, low-intensity signal within the cervical spinal cord itself, which is known as a syringomyelia or a syrinx. And so the patient was referred to neurosurgery, who performed a suboccipital decompression, and his symptoms resolved. Now, this is a beautiful little girl who is part of our practice. And I want you to pay close attention to the repetitive stereotype movements of her hands. She has a condition known as Rett syndrome, and this is a genetic disorder which occurs in 1 for every 12,500 female births. It is a mutation which occurs on the X chromosome, 95% of which are de novo. And this results in a progressive neurodevelopmental disability in which, over time, their head velocity slows and they wind up developing microcephaly. As I stated earlier in my presentation, they have a dysregulated, dysrhythmic breathing pattern, both during awake and during sleep. During the awake period, they will have periods where they will just become apneic and will need to be stimulated in order to breathe. At night, they will exhibit repetitive bouts of central mediated apneas. As I've just demonstrated to you, they have unusual stereotype repetitive movement of the hands. They wind up developing intractable epilepsy along with their global delays and loss of coordination. In this particular girl, she had developed epilepsy and was being treated with 2 anti-epileptic medications listed there as Tegretol and Topamax. However, her mother came for a routine follow-up stating that her sleep patterns had become increasingly disrupted with the development of nocturnal arousals, parasomnias, and respiratory pauses. And her sleep study demonstrated that she had 40 central apneas, all of which were in the non-REM state, for a central apnea index of 5. Topamax had not made an impact on these central apneas, and I'm going to discuss that issue towards the end of my talk. So a BiPAP trial was ordered. And this is an example of her sleep study. And what you can see in the EEG channels is you can see these very long runs of spike and wave discharges that were associated with the central apnea just below. And that was associated with a drop in oxygen saturation of at least 4%. So on BiPAP settings of 7 and 4, we wound up having a marked reduction in our central apneas and eliminated what few obstructive apneas and hypopneas were present. Oxygen saturation was able to be maintained on this setting. Her arousals came down, and as a result, her sleep patterns, once they became more stabilized, she had less parasomnias, she had less sleep fragmentation, and this helped to improve her seizure frequency. She started to seize less because her sleep patterns became more stable. Our third case is a little girl who was transferred from Honduras. Her family were missionaries, and their child began to develop seizures while she slept. And she was placed on anti-seizure medication, which unfortunately not only did not control her seizures, but resulted in a number of adverse side effects: weight gain, hair loss, tremor. And she was sent to the United States. We saw her in the practice, and while we were performing a routine EEG, the child fell asleep and started to exhibit long runs of subclinical seizure activity, during which time my EEG staff noted that she began to exhibit symptoms of apnea. Now, again, this was only EEG monitoring, and so we set her up for polysomnogram testing in our office and documented that with these near continuous discharges during sleep, she had numerous central apneas. I changed her anti-epileptic therapy from Depakote to Trileptal. She became seizure-free, and on follow-up polysomnogram, central apneas were reduced to only 5 events. And this, again, points out the association between epilepsy and central apnea. There are 2 studies that have been cited in the literature. The first by O'Regan and Brown, who evaluated 37 children with epilepsy who experienced changes in respiratory pattern in association with their seizures. And in this study, 40 partial seizures were captured. And of those 40 partial seizures that were observed, you can see that apnea occurred in 30% of those cases. The second case documents by Tetzer 2 reports of central apnea in association with captured partial seizures. In case number one, the patient became improved when their anti-epileptic medication was changed to trileptal, and I used that particular study to rationalize the choice of medication change. In the second case, the patient improved once there was a temporal lobectomy. And our final case is going to discuss a child with an 18-month-old child who exhibited bilateral intraventricular hemorrhages and subsequently underwent shunted VP shunt placement for hydrocephalus. This child presented to one of my partners with symptoms of irritability and nocturnal arousals associated with screaming. And a polysomnogram was ordered, which demonstrated 12 central apneas, which resulted in a central apnea index of 2. The concern was that these events possibly represented evidence of seizure, i.e. nocturnal frontal lobe epilepsy, and so an EEG was ordered to assess for this. An EEG failed to demonstrate evidence that these events were seizure, and so a repeat polysomnogram was performed, now demonstrating evidence of a progression in the central apnea index, which was now becoming associated with oxygen desaturation, and the symptoms were also progressing in terms of their severity. So my partner asked the neurosurgeon to evaluate the patient's shunt. So we obtained an MRI of the brain, which demonstrated that there was a significant increase in the size of the ventricles, and that what you can see on the arrows is that the VP shunt was not only kinked, but was no longer sitting within the ventricle itself. And so, as a result, neurosurgery was able to determine that the shunt was malfunctioning and performed a revision, and her symptoms resolved and her sleep pattern stabilized. So what these cases have illustrated to me and my colleagues is that the polysomnogram can provide enormous information, not only in terms of diagnosing conditions, but also screening for the development of disease. And so we have taken it upon ourselves to consider ordering MRIs of the brain when we note that there's a central apnea index of greater than 2 on the polysomnogram in order to screen for Chiari malformations or brainstem anomalies. We also consider ordering polysomnograms on our patients who have VP shunts who develop sleep disturbance in order to screen for evidence of central apneas, which could suggest shunt malfunction. And lastly, we consider ordering polysomnogram in epileptic patients who are experiencing sleep disturbances, which may help us to screen for central apneas, which suggests that we may need to change anti-epileptic medications. So when it comes to the treatment of central apnea, there are 3 primary methods. There is positive airway pressure therapy, use of medications such as hypnotics, and the use of acetazolamide. But in children, I'm going to briefly discuss my experience in using a anti-seizure medicine known as topiramate. Now, PAP therapy is used for central sleep apnea to increase pCO2 during sleep in patients who are hypocapnic. It helps to prevent upper airway resistance from inducing arousals and prevents significant negative upper airway pressure. The use of hypnotics helps to decrease arousals and increase N3 sleep when respirations begin to stabilize. And acetazolamide is a carbonic anhydrase inhibitor, which induces a metabolic acidosis, which then helps to stimulate minute ventilation. And so when I was faced with these children who were exhibiting high numbers of central apnea, I quickly discovered that they were intolerant in using acetazolamide because of adverse side effects. But Topamax is a medication which also works through carbonic anhydrase inhibitor action to induce that metabolic acidosis that was previously discussed. Topamax is a medicine which is studied in children. It's federally approved by the FDA for children as young as age 2. And so I initiated a very small dose of this medicine, anywhere from 12.5 to 25 milligrams at bedtime, and then repeated sleep studies at an interval of about 6 to 8 weeks. And what I saw, as you can see in this abstract that I published at the Sleep 2012 meeting, was that we were able to see marked improvement, both in terms of a reduction in central apneas on PSG, but we also were seeing dramatic improvements in clinical functioning, as reported by the parents. So our age range was from age 3 years to 12 years. Our central apnea indexes were ranging anywhere from a low of 1.2 to 10, with a mean of 3. And after treatment, we were able to reduce central apnea indexes from 0 to 0.2 to 1.8 range. And so as a result, this was marked by a reduction of anywhere from 44 to 93%. The children tolerated the medicine well, and once their patterns of sleep began to stabilize, a lot of the clinical symptomatology that they were experiencing also dramatically improved. And so this is just a small sample of how using polysomnogram in my private practice has really significantly changed the way I practice medicine and the kinds of conditions that we're able to not only identify but effectively treat in this pediatric population. And so I would be very happy to entertain any questions that any of you in the audience might have in terms of how I established my sleep lab or how I run it,